Great. I think this is recording, so we'll go ahead.
Let's go. 5, 4, 3.
You just always wanted to do that.
Of course.
This isn't a video, so...
damn it.
Hello, welcome, good afternoon, good morning, wherever you are in the world. This is the Study Success Blueprint. Hello, my name is Matthew Mace. This is the Study Success Blueprint. I have a wonderful guest with me today, Dr. Kunjan Bhatt. He is a cardiologist, heart failure specialist, director of research, and the lead for amyloid here at Austin Heart Hospital in Austin, Texas. Thank you very much for joining me.
Matt, thank you for having me. It's a pleasure.
You know, we start out every one of these podcasts with the same questions. What is it that excites you most in your field today?
I don't know where to begin with that. That's a fantastic question, but it's very broad. And I think one of the things that has drawn me to heart failure is the innovation that's happening in this field is going at a mind-boggling pace and speed. Unfortunately, during the pandemic, I had a few years of a hiatus where I didn't go to conferences just by virtual, but went to my first conference in Boston and we met there and was able to kind of rekindle that flame of why I'm doing what I'm doing, which is we practice a field of medicine that is highly morbid and highly mortal. And I see patients who have heart failure every day, and it's humbling, it's traumatizing, it's a very, very difficult disease for our patients to manage. And to go to these conferences, to see what's happening at the cutting edge, be it industry, be it device, tech, medications, what the future looks like, I think is awesome. So what really has attracted me to remain not just engaged, but really kind of wanting to move the needle in our field is the fact that innovation will breed excellence. And when you and I, joined forces over a year ago, I saw this passion and this really incredible clinical question in your company of something that I felt we could jive and have a good synergy. And the rest is, as I say, history.
So excited about other people's excitement and energy that they bring to the space and innovation. Is that fair?
I think it's like one energy feeds off the other, if I can use that expression. I think previous myopia of just what's happening in my practice when I started 17 years ago, the blinders have come off. My sleeves are rolled up and I'm ready to get down and dirty and figure out what are we going to do about this disease going forward. Mm-hmm. So absolutely enthusiastic. And I feed off of enthusiasm. I've definitely fed off yours.
That's very kind. Feeding off energy leads very nicely into how do you see the level of collaboration that we have in your field and wider academic fields?
My challenge with the collaboration is I try to maintain a practice hat, a research hat, a collaborative hat with my colleagues around the world, my family, and try to wear these different hats on a minute by minute, day by day, hour by hour basis. It's challenging, but the broad collaboration that's there is boundless for the right person. Mm-hmm. I think you have to have the energy and the infection to want to do it, mm-hmm. because it's very easy also to shut the phone off, not respond to emails, bury your head in the sand. And I know several people that do, and it works for them. Mm-hmm. I can't sleep at night doing that. I need to be part of that pulse. Mm-hmm. And that's sort of just what drives me and what innovation excites me. Mm-hmm. And with that comes the ability to speak to my colleagues around the world. And with that comes these added bonuses and challenges.
We've known each other for a good year and a half now. It's incredibly tough job that you have, 1 as a cardiologist, 2 as a researcher, 3 as a dad, 4 as a leader of this academic field that you're around. How challenging is that to divide your time to make sure you give everything to all of those facets?
I don't know that I have it down pat yet. And I'm not sure even sailing into retirement at some point in the distant future that I'll have it down to a science. But I constantly talk with my family to see what can I do differently to get home. Because ultimately, I want to make sure I bring at least my A game or A- game home and not my C- game home. I'm early to rise. I'm usually up by 4 a.m. to try to get some modicum of exercise in. And then off to the races, looking at computers and looking at my patients' portals and vital signs. Then I meet my team, we round, we do clinic, and we call it a day. But after a day's done, there's imaging to read. There's sponsors' emails to get to. There's my research coordinators that have clinical questions. There's your family that gets sick. You have elderly parents that need medical attention, as mine did today. And things just come up unannounced. And I think that's just the challenge of life. So I don't think this field, no pun intended, is for the lighthearted. I think you have to have a strong constitution. I think those who want a linear schedule, this is a difficult field to be a part of. The professional and the personal life struggles are real. And that's just the fact that I've got a daughter who just graduated high school that's in college. So she had her senior year journey. My son's a 15-year-old sophomore, and he's a great kid. Just, he needs attention. And then, of course, at the end of the day, making sure that I'm a decent husband. I've got a wife I've been married to and who's been just probably the most incredible gem of a human. I've known her for now 27 years, and we've been married for about 23. So I'm a lucky man to know Rupal. But these are all different things that come into my mind every day on how do I do a better job. So I think complacency will be my defeat in one of these facets or multiple facets of life. So I'm always thinking of how can I evolve to do a better job, especially on the home front.
It's definitely not for the faint-hearted. Being part of research, running companies, whatever it is, and I don't think anyone has balanced the books on all of those. Talk to me about what's the research practice? Why did you take it up a year and a half ago? What was the drive? What was the state of it? And where is it now? And where do you want it to go in the future?
Yeah. So the practice of Austin Heart began in the late 90s. So almost 30 years ago, it was a merger of several groups that then grew and grew and grew from Central Austin to then Central Texas. We now have 13 full-time offices. We cover the square footage of the state of Maryland. So we have a fairly large thumbprint in Texas. We have 50 cardiologists, about 30 APPs, and a good reputation. We have a very good reputation here, and we've had one for 30 years. Research complemented our growth. One of the things we pride ourselves at Austin Heart during our heyday in research was we were the busiest private practice research program. When I joined the directorship role, we were a bit in shambles and had no fault of my previous partner. It was really just the fact that COVID happened. So research shut down. And so therefore budgets shut down. And so I think that ripple effect affected me even 2 years later when I took the roles in 2022. What I recognized coming into the leadership role is it takes a lot of sweat equity to make things happen. And the time I put in, unfortunately, cannot account for what came of it. So we have a good momentum building now 2 years later where we have a great trial portfolio. We currently have 30 ongoing trials, either actively enrolling or completing enrolling in follow-up. And we have about another 15 to 20 on the horizon. So we'll have somewhere between 40 or 45 trials that will be either actively enrolling or in follow-up phase. And that's a sizable portfolio of trials. And I think the other part that I have to bear in mind is I'm in a cardiovascular practice. I'm not just in a heart failure practice. And as a heart failure specialist, maintaining a portfolio that's attractive to my partners and attractive to my patients is important. And that equipoise is important because I think at Austin Heart, we really feel that we want to lead these trials. And it's not just for numbers, it's for the fact that we want to move the needle.
It's important when you consider trials, and I was discussing this the other week, which is it's a very long-term game. It's a very methodical, I'm not going to change the practice overnight. I'm not going to get 20, 30 studies just fall on my lap just because I did one post on LinkedIn that says, hey, we're open. Like, it's a slow practice that you are going to face ups and you're going to face downs and you're going to face rejections and you're going to face interest. It's taken 2 years to get to a very nice, respectable practice. If you did it again, if you were 2 years ago, is there anything you would change about your approach to get that cadence?
I probably don't micromanage enough. I do have a bit of a laissez-faire, hands-off approach to management. And I think to make sure that my team feels the momentum and the expectation that we're going to excel. And I'm not just singling out my research coordinators, I mean my partners, my patients, to help them understand how things move in our field.
Mm-hmm.
That innovation and how important it is to be omnipresent without being annoying. I think that would have been maybe one thing I would have done a little differently. And then it's not enough to enroll. It's to make sure that we have high quality research, right? We want to make sure our data entry is accurate. Our bookkeeping is spot on. We just have to make sure that we're meticulous. I know that when you and I collaborated, we did a study for the Acurai company and really hit it out of the ballpark because it was something that as this trial came to evolution, I had pre-meetings with my 3 different hospital systems, and I got my partners excited. And I think as it was a cath lab oriented study, it was an easy clinical question /cell/science. So I think getting behind that was not difficult, and we're lucky to lead the country in referrals by a lot. But I think it really took a lot of momentum beforehand. And I don't know that I've done that successfully with each launch of each trial. That's not even mine, but just in general in our research portfolios. I think it's just maybe being even more present without being annoying and maybe being a little bit more hands-on.
Mm-hmm. It's a little bit interesting. When I spoke to Dr. Andrew Sauer the other week, we talked about how you find the champion, but actually when you drill down, it's about excitement. And a research program isn't just one person. I think we are very good at seeing such and such research program over in, the northeast of the US, led by such and such a person, but actually there's 60, 70 people underneath making that happen. They're not the PI on every study. How do you think we could get better foresight, make sure we drive excitement? How do I make sure that there's enough runway, there's enough road in front of the trial to get the right champions, to get the right excitement, to make sure we're engaging, rather than just say, oh, we have a trial they're running next week. Please enroll your patients. Thanks. Like, that's just a text. That's not how to get people engaged.
Right. I think you're going to have to build trust with sites first, right? So there are certain sites that have a reputation for a reason, good and bad. And I think that's a fact. And I think that's something that we've prided ourselves on, being that sort of a site where sponsors are eager to come, or at least know of our name and of our reputation and our clinical excellence and our quality and quantity of enrollments, to come to us saying, hey, we hear you guys do a good job. Would you consider this study? The other part that I think is perhaps not spoken about enough, but I think it's maintaining all eligible people that are excited to do research to be champions. So now that I'm in this leadership role for 2 years, the PI role comes to be very easy, but that doesn't help my partners that may be equally excited, if not more excited than me. And if I don't give them a chance to spread their wings and fly, we'll never know. So 1, I can't do it all. And 2, their feverish excitement is something I must invest some time into and resources into, to know that my physician colleague who's been with us for, say, 5 years, he or she may be a perfect target for a PI. And I think singing the praises of your partners and your research coordinators goes a long way. Letting your team shine, whether it's on the podium at a national stage or by a group email, these are the sort of things that I think engage my research coordinators. But it's not all about money. It's not all about payment. It's about the quality of work we do. And I think it's just like feeling that you feel the accolades. So getting my partners engaged, getting my research coordinators engaged on the podium, on stage, or even recognized through emails that go up to upper level management goes a long way.
Mm-hmm. I'm a big fan of getting more diversity on stage. And that's not just diversity in terms of race and ethnicity, but that's just diversity in the sheer number of people. And when you find PIs and you find research coordinators and you have a team and you have to spread the love, right, between everyone, do you have a checklist? Do you have a way to equally distribute interesting trials, interesting studies, finding who wants to be a PI? Is it the clinical question that drives that? Is it now your turn? How do you approach that from a management perspective?
The 50 physicians that I work with, having worked with some of them for my entire career and some of them just for a few years. But part of my job in leadership is to know the personality of my partners. And some of them have expressed to me, I'm good with referring, but I don't want to be engaged in the leadership part of research, i.e. I don't want to be a PI or even a sub. Okay, that's fair. That's always good to know. Others have expressed an interest in being an investigator, and it's always good for me to know that. The other part is that as we have 3 research sites in our practice, so not unfortunately all my partners will be able to be PIs, as they have to be somewhat connected to those 3 full-time sites. But that's not to say that those physicians can't engage in research. It'll be difficult for them to be leads unless they're willing to pick up their practice and spend some time with the research coordinators for a couple hours a week. I have 3 structural colleagues who are phenomenal physicians, And I eagerly looked for structural trials, or they bring me structural trials saying, there's this new aortic valve, mitral valve study. Can we engage? And the answer in general is yes, let's do it. And furthermore, you're engaged. So that's what matters the most.
Mm-hmm.
Out of 50 physicians, I probably have about 10 to 20% of them that are highly engaged with research to want to be PIs. I engage them. We rotate the schedule as much as I can to maintain some level of balance. And I don't think, not to my knowledge, that I've excluded anyone who wants to participate. So, I hope not. Remains to be seen.
You might find out at some point. What I mean, it puts a lot of pressure on you as the director, as the leader, to engage, speak to, be the champion. You never sleep, right?
It's a commodity. It's a hobby.
But what do you think sponsors, industry, CROs could do to help you?
So I think there's several steps along the way with how sponsors, CROs, and research sites engage. There's your established practices that sponsors and CROs know. We'll call them your OGs. There's not a lot of dating to be done. This is an established site. We know how they work. We know their startup times. We know what quagmires we run into, and we know the quality of their work, and we want them. I think the thing that I've discovered in this resurrection of our research practice over the last 2 years that I've tried to do, one of the frustrations I've faced is I think I've expressed this to you in no uncertain terms. I strongly believe in our practice, and I strongly believe in our physician engagement, in our ability to knock trials out of the park, provided they're the right fit bidirectionally. The challenge I face is recently there was a study I was eager to do. I was trying to maintain a good cadence of communication with the CRO, only to be told that we were not selected. And it was disappointing because I provided data. I thought I put our best foot forward, but yet I don't know why we failed. And when I asked the CRO this, they said that the sites in Texas have been filled. So as a quota system, which I get it, but it's one of those things where you think to yourself, okay, there's several large cities in Texas, and why did Austin get ignored? I believe I was the only site in Austin that was looking for this study. And at a certain point, you have to kind of just, fish or cut bait, and I had to cut bait because at a certain point, you don't get the same dialogue back from the CRO, and it starts to feel like sour grapes. What I think would be helpful is transparency from the get-go on a novel relationship, where if it seems like it's going to be an uphill climb to engage in a clinical trial, then I think it's very fair for them to say, hey, it's not likely we'll be able to get you guys on board, but feel free to try. That would be for the upstart trials of, hey, here's what we have. I think you guys potentially could be a good fit. This is the ideal site we're looking for. That checklist would be very helpful for a first date, right? Because if it's a bad fit, if they're looking for a large academic practice where they have cardio-oncology and they have cardio-obstetrics and they have these super specialty practices in cardiology in an academic sort of mecca, well, then my practice may not be the right fit for that trial.
Yeah, it's a non-starter.
Another thing that would be super helpful is these SIPs, site initiation platforms that certain CROs have are difficult. It's like uploading CVs of all your partners, of yourselves, your research, and refining that and doing that per sponsor or per CRO is a massive waste of time. And putting that on some platform where a sponsor or a CRO can see this, and there's no reason to ask these questions again and again and waste sort of each other's time, where if we can put that information out there in some secure platform, it would be immensely helpful and avoid all these redundant things that we do.
It'd be great if someone was working on that.
I know, Matt. I'm at a loss.
Transparency is a word that means different things to different people. But I'm going to use a slightly different word, whether you agree. I get the sense that the relationship between a sponsor and a site is sometimes seen to be unidirectional. It's sponsor wants to ask the question, goes to the site. I'm pushing down. It's a one-way street. And I've never believed that. I think it is a very strong collaboration, and collaboration isn't an overused word. But do these platforms, the amount of admin, does the lack of transparency make it feel like it's a one-way street that is not a synergistic balance of benefit?
Completely. I think that, look, I'm not playing the victim card here. I think we also have asks, and so we're never going to dance unless we want to dance, right? No one's forcing us to be part of a clinical trial. But when a sponsor says we're going to pay you on a 90-day schedule, how does that make sense?
Mm-hmm.
And that conversation was had today with me, my admin leadership, and a sponsor. And so in that study, we had to sort of say, look, we can't function that way. I know you're not cheating us out of money, but you're certainly paying us on this very delayed schedule. And it's almost on a Q1, Q2, Q3, Q4 schedule. That doesn't make sense. And so I fully understand that they're launching something, the level of risk they're accepting is high. And we are part of their quality program. So we can potentially sink them or help them elevate.
Trying to bring all of that together, how compatible do you think private practice and academic research is?
I think for the right individual and the right mindset, it can be very compatible. Do I make more money doing research, the way I do? Absolutely not. I could be more efficient with my time and be seeing more patients. I do this for the love of the game.
Mm-hmm.
So I do think it takes a special person to do research in private practice, because at a certain point, Matt, it's not about money, right? It's about what legacy do I want to leave behind when I finish practice. And I want to feel like I made a dent in the field of cardiovascular medicine, and especially in heart failure, but just in general in cardiovascular medicine. But I also want to feel that my practice, my healthcare system shines. My happy place is when everyone elevates their game and does well. I don't think that everyone in my practice necessarily wants to go 110 miles an hour seeing patients. I have some partners who do that, and it's great to have them because they have an immense base of patients to choose research trials and enroll into. So I think we have a great synergy where we have highly productive people. Maybe they're not as engaged with wanting to be PIs, but they'll be open to enrollment for their patients.
Mm-hmm.
Then we have people like me who I'm busy. I'm not maybe as busy as my other partners are, but busy where I feel comfortable that I do a good job, but also I can spend some time in my love language, my research time. And that is something where I feel these discussions I have with people like you, with people around the world, I can really feel the pulse of what's happening in cardiovascular medicine.
Mm-hmm. There's a delta and there's a benefit for the practice. Now, I have a bias. I think commercial sites, private practice is phenomenally important for research because that's where the real patients are. And I think research is a love game more than a finance game. Bringing in innovation can only be done by research is my view. Do you vibe with that?
Absolutely. The majority of cardiovascular medicine is managed by private practitioners in this country. Again, if you think about where the majority of patients being managed, it's being managed at your local family practitioner, your local cardiologist. That is where bread and butter medicine occurs. So I ask you as a call to action for a sponsor/CRO in the future, if that's something that you are looking to engage sites, you must maintain a balanced approach to that. And I think it helps maintain a balanced patient demographic where it's not just a zip code in inner Dallas or in inner Houston or in inner San Antonio, but Austin belongs too. And I shouldn't just say Austin. I should say the majority of Texas is rural.
Mm-hmm.
And that may not be appropriate for the disease that they were studying, but it's important to have a mix because a lot of patients that I see who have specific cardiac diseases don't live in this zip code. They live far away.
Yeah. Your energy is infectious. I hope, those sponsors, CROs, investigators at other sites are listening, right? Because I fully believe that you have to go where the patients are and don't make the patients move. I applaud you for all of the work you're doing here. I think it's fantastic. Austin has a place in my heart from my days at Abbott and St. Jude. But building a practice is hard, and building up the awards and accolade and the status again for the group is going to be an ongoing challenge, but one that you have passion. I'll leave it with this, which is, and we'll go back to the start. Family is everything, whether that's your work family, whether that's your home family, whether that's the family that you were educated with. What would be the hope that you have for the next couple of years for how all of those dimensions are developing in your life?
I want to always lead by example. And I think that if I can show my patients that I'm giving them not just my full attention, but everything that's cutting edge so that they don't have to travel halfway around the world, halfway around the country to get that cutting edge technology or that research device or trial. I want to make sure that I continue to put my A game forward for my patients. I want to make sure I put my A game forward for my partners. And that is to say that you don't need to refer your patients outside of our practice for anything. Not cutting edge valve disease, not cutting edge lipid therapies, not cutting edge research, nothing. Everything stays within our practice because that is who we are. We are Austin Hart. I want to make sure I do well for our healthcare system. I'm lucky and blessed to be with the same healthcare system for the past 15 years. And they've encouraged me to continue to go in research. And I'm hoping that I can engage the healthcare system continually and maybe even through not just the heart hospital, but through other hospitals in the St. David's networks. So hoping that we can grow. And I'm hoping I can lead by example for my kids. My daughter, I think she drank the Kool-Aid, and I think she may be taking the plunge into medicine. She's 18, and so she's young in her college career. So obviously the world is her oyster, and we'll see where she lands. I want to be the best I can be professionally and personally for her and my son. And at the end of the day, I've got to have a date night. Rupal and I need to hang out. And so I think that's the challenge. Where I see this evolving is I do think at some point I'll need to probably scale back some part of the practice. I dare not say research because that really, my Wednesday afternoons are my happy place when I get to talk to my research coordinators and we talk about the trials. But something's got to give. And I still feel like I have a lot of energy, so I don't think I'm ready to scale back yet. As I mentioned to you, sleep is a hobby. So I don't sleep. I don't necessarily get my 8 hours of sleep a day. I probably get a fraction of that, but it's okay. It's allowed me to function and do what I want to do. Is this something that's necessarily healthy? I'm not sure. I'm not sure that this is the healthiest way to manage my overall being. Am I happy? I'm immensely happy. I love what I do. And there's not a single facet of my practice from Monday through Sunday, professionally and personally, that I don't love doing. And I think that's what I've told my family, my work family and my home family, that when I stop doing what I'm doing, I'm done.
Mm-hmm.
And I don't even feel an iota of that yet. I mean, not to say I don't get frustrated, not to say I don't feel overwhelmed at times. I'm human. I mean, if you pricketh me, I do bleed. I think to continue to feel that I want to be feeling this pulse with my partners from across the country, my kids can see that.
Mm-hmm.
And what do I want my patients to see? I want them to see that not only is seeing one of my partners good for them, but that they will be afforded the best care in every facet of cardiovascular medicine. And that's what I'm hoping that our legacy is here.
It's truly inspirational.
Thank you, Matt.
Thank you for having me down here. Thank you for giving up your Wednesday afternoon to speak to me. You're one of the nicest guys I've had the pleasure of meeting, and you can't get rid of me. So,
well, I did it for the free beer. I'm not sure what you're talking about.
Oh yeah, that's. Is this a dry state?
Not today.
Well, thank you, and we'll leave it with that.
An honor. Thank you, Matt.
Cheers. Appreciate it.
Cheers.
Man, that was so much fun. I'd like to thank Kunjan Bhatt for joining me and taking some time out of his busy and insane schedule to record that podcast. If you like this and you would like to listen to more, please subscribe wherever you listen to podcasts. You can also listen back to our last episode with Anil and John from Bridgesource Medical, where we discussed the role of government in innovation, and look forward to our upcoming episode with Alana Rice, as well as in the future industry professionals from the United States and Europe. So with that, I can leave you today. Speak to you very soon. I've been Matthew Mays, and this is the Study Success Blueprint.